NREMT's Clinical Judgment webinar series titled Decisions in Depth, Mastering Clinical Judgment on the Streets, presented by Dr. Bill Young. I'm going to pass it over now to our presenter. Dr. Young, thank you so much for being here with us today to share your knowledge and experience with us, and we look forward to the presentation.
Thank you, Rio. I really appreciate that. And so, welcome everybody. This is really important because we're seeing some big changes that are coming in our profession, both from a clinical as well as from an educational perspective. So, my name is Bill Young. A little bit about me. I've been in EMS since 1975. So, yes, that makes me very old. As a matter of fact, last year, my students threw a surprise birthday party for me, and I'm looking at a dinosaur that they had on my cake. And so we had a good laugh about that. But I've been around for a very long time, and I've been really excited about some of the changes, some of the positive changes, and even maybe some of the pain that we're going through as a profession right now, because I believe we're going to come out stronger, better, and I do believe better paid on the back end of this if we can follow the science. So this is part of a series of presentations that we have been given around the country, both face-to-face and online, in regards to clinical judgment. So the first thing we got to do is so what's the big deal here? So the key to keep in mind as far as when we're going through this presentation today is that the National Registry is changing their exam. Now, here's one of the key things that I want to make sure everybody understands. National Registry is not a standalone educational evaluation program. They have to follow some pretty stringent testing standards. And so one of the things that they have to do is they have to periodically look at best practices and see what they're doing that is really, really strong, and some of the things that they're doing that not so strong. And in some of the meetings that I've sat in on the National Registry, one of the things that they found out was based on their accreditation agency, and so yes, they have to be accredited as well, is that they had to do away with the psychomotor exam. Now, I will be quite honest with you and tell you that I am thrilled to see that go by the wayside for a number of reasons. But the other thing that we're looking at here is that they had to begin to change and follow, again, you'll hear this phrase quite frequently, some of the best practices as far as testing goes. One of the things to keep in mind as we get ready to make this transition is that this is, to a large degree, what you as an EMS educator are already doing. And so that's the good part, because none of us, myself included, have time for additional busy work. And so one of the things that we're going to talk about a little bit later on today is why this is important to you as an educator and why this is important to you as a student. But here's the other thing to keep in mind. What registry is doing with their new exam, again, based upon this concept of clinical judgment, has been done for a number of years. As a matter of fact, I talked to the director, Bill Seifert, who I have great respect for. I really do. I think registry is probably in one of the better positions that it's been in since its inception. And he shared with me that pass rates actually went up when nursing and social work changed over to this different type of exam that focused in on clinical judgment. So I'm hoping that the exact same thing will happen with our students, because we do need to get more competent providers out in the field. So exactly what is this? For a number of years, I like to spend as the director of education for the Kentucky Board of EMS. I like to tell people I'm a recovering state regulator, but in that position, I learned that definitions are important. So exactly what is clinical judgment? Well, first of all, clinical judgment involves the cognitive process, this whole process of clinical reasoning through which paramedics and EMTs can make a decision using both objective and subjective data that we gather in our patient assessment and the evaluation of our patient during that time that we're with them. According to an article from the Journal of Evaluation in Clinical Practice, and I'll have a reference list for you at the end of the presentation. Clinical judgment is honed through practice, experience, and accumulated knowledge, as well as ongoing critical analysis. Now, we all know that the best way to get experience is by making mistakes. And what we want to do for our students is that we want them to make those mistakes to where there are little to no long-term repercussions other than a positive impact on their learning. And so this is the approach that we're taking from NREMT as far as trying to help all of us get ready for the new exam. Clinical judgment plays a very crucial role in various medical domains, including the diagnosis of our patient. Yes, we do diagnose. The treatment therapy that we have, how we communicate, how we talk with our patient, and ultimately the decision-making process that we all employ when we are assessing and caring for patients. Now, it's important for us to remember that clinical judgment as a paramedic or as an advanced EMT, even as an EMT, is not just a skill, but a very critical component of daily practice that allows us to deliver high-level care to many different cultures, many different diverse populations, diverse areas around the country, as well as one of the things that I enjoyed most about being a paramedic was being in an unpredictable environment. This decision-making process involves a interplay between theoretical knowledge, that's the cognitive part that's learned in the classroom, as well as evidence-based practices and different frameworks that the student can put into action first in your sim lab, then in your clinical area, like the hospitals, and then finally functioning as a team leader out on the ambulance itself. So why is it important? Well, this came from a nursing website. Most of the data that I'm gathering today comes from nursing because we don't have a lot of data yet on clinical judgment within EMS. And I found that this was really interesting. It says that 46% of tasks performed by entry-level nurses are linked to clinical judgment. Well, that just kind of makes sense. If we're going to do something for a patient, then we need to know exactly why we're going to do that. Over half of novice nurses, and by novice nurses, they define this as nurses that had less than 1 year of experience after gaining their licensure, they're involved in patient safety events and critical incidents. What we don't want to do is we don't want our responders making these critical mistakes in the field. Now, we know that we're all human, so we're going to make mistakes. So totally eliminating those, not going to happen. But what we do want to do is, number one, we want to minimize those. And number two, we don't want those to be repeatable. I'll give you some strategies that you'll be able to utilize in just a little bit to actually bring those out. And then last, it said 23% of new nurses can safely recognize urgent changes in a client's condition. Can we tell the difference between sick versus not sick? In this situation, only 1 in 4 of these nurses could actually identify that our patient is crashing, as well as identify what's going to be happening for them. Now, I caution us to be really careful about drawing any direct interaction from these stats to EMS. And the main reason being is that for many situations, nursing has a much longer standing history of teaching patient assessment and teaching a detailed evidence-based patient assessment than does EMS. So ours may be higher, they may be lower as far as these things go. So ultimately, in adult education, and this is what we're all doing, learning more about EMS education, the bottom line question has to be answered. Why is this important to me? What does this mean to me? Well, as we said a while ago, paramedics often operate in scenarios where rapid assessment and immediate action are required. As a result of this, clinical judgment now involves synthesizing information from multiple sources, including your patient assessment, getting a good history on a patient, and trying to make sure that the history is accurate, as well as a situational context, looking at the area around the patient, whether it's in a house where we potentially see drug paraphernalia, or if we're out on a auto accident where we've got an unknown fluid that is beginning to leak. And we put all these things together and we make informed decisions really, really quickly, very, very quickly. Critical thinking and clinical reasoning play pivotal roles here because it allows the paramedics to analyze all the information that we get from here, analyze potential risks both to themselves as well as their partner and to the patient, and then prioritize the interventions, going from what do I need to do first, second, third, and fourth. That's going to be a critical area, especially as we begin talking more about the different types of questions that you're going to see, because within the new exam, there is some prioritization that's going to be taking place. Paramedics utilize the knowledge from other disciplines such as pharmacology, psychology, anatomy, and physiology to make these types of judgments. And one of the things I'm really happy to see is that we're beginning to move out of the silo of only EMS response to now beginning to take an interdisciplinary approach, because this multi-pronged approach enhances our abilities as paramedics to manage complex cases from trauma injuries to acute medical emergencies, ensuring that the decisions that we make are comprehensive and that they are tailored to patients' individual needs. So ultimately, what we're looking at here is patient outcomes. Now, by patient outcomes, I'm not talking about a patient satisfaction survey, but what I am talking about is does what we do as an educator in teaching our students, and then those students taking and implementing that information out in the field, does that help our patient in the long term? The quality of clinical judgment directly impacts these patient outcomes in paramedicine. If we have really good, effective clinical judgment, this can lead us to an accurate diagnosis, which allows us to now begin the correct treatment in a timely manner and to follow up with any additional treatment strategies that would be needed that are often crucial for the patient's survival. As we've shared many times, what we do in the field has a direct impact on, number one, whether the patient survives, and number two, how long they stay in the hospital. For example, in the past, we used to be really, really quick about getting patients intubated and getting them ventilated. And then comes along CPAP. And CPAP has been a godsend to keeping patients off of ventilators, which positively affects both their physical outcome as well as their financial outcome, because a ventilator bed in a hospital costs multiple thousands of dollars each day. So if we can prevent, legitimately so, an intubation, and we can teach our students those situations in which they don't want to intubate, but we've got alternate methods, then this is going to be really, really good for our patients. Because of this, fostering strong clinical judgment skills is a priority in the paramedic education process, as well as ongoing professional development, both for your students as well as for us. If we do this, we will ensure that our students are well equipped to meet the challenges of their new roles, because the challenges are multiplying. There are some things that paramedics are now doing that only a few years ago were relegated to the world of physicians. For example, finger thoracotomies. Just a few years ago, only physicians were able to do this, and now that is within the scope of practice. Looking at the administration in the appropriate situations of whole blood, that's now beginning to become commonplace, not only in urban areas, but rural areas as well. Now, one of the things we've got to kind of keep in mind here is that clinical judgment is a critical component of healthcare that uses both instinctive and intuitive reasoning. Another way to put this is you're going to use both your head and your heart. One of the things that I do, I've got a presentation, and if I'm not mistaken, an article will be coming out in the domain in an upcoming issue in which I compare intuition for an EMS responder to the gut feeling that NCIS Special Agent Leroy Jethro Gibbs has on that popular television show NCIS. Now, there is some valid scientific evidence-based rationale that intuition actually is a real thing. And one of the things that I like to tell my students is that many times that they'll have a feeling, a gut feeling about a patient when the information that they have in front of them really doesn't necessarily indicate the level of severity that they feel about. Now, as far as this process goes of both using the head and the heart, these are two types of reasoning that is really, really important and very, very valuable. And we gain a more accurate use of these as we get more experience within our career. Both of these act in a complementary manner, and it's well supported in the literature. According to a scientist, last name of Krosky, who posted in 2009 in the Academic Medicine Journal, intuitive reasoning is best for fast and effective decisions. We got to make a decision really, really quick. We make it on limited information, and that intuition that we have gained gives us the edge to be able to make a good decision for our patient. And again, this comes into play here by getting more and more experience because our subconscious is able to take some of that information in, process it much faster at the subconscious level than we can at the conscious level, and help us to make some really, really good decisions. The intuitive type or the reasoning part, the thinking part is much slower. And we'll talk more about this with a psychologist that just recently died, one of my favorite authors by the name of Daniel Kahneman, in a book that he had written called Thinking Fast and Slow. And he's one of the main proponents of this, using both types of thinking systems. Now, we're very well aware that paramedics often will toggle back and forth between these modes, depending upon what the situation is within the clinical presentation, as well as how complex it is, or how immediate a response is going to be. So if we're looking at a patient that is having SVT, I talked with a student today, and we were going over a case study where I'd given them, and she said that she was looking at an infant that was in symptomatic VTAC. And her selection was, well, I would start an IV so that I could give some pain medicine before I cardiovert. And I said, well, that's your compassionate side coming out, which we don't want to dampen down. But the right answer in that is actually going to be, we're going to go directly into synchronized cardioversion because our patient is not stable and they are not going to survive long enough for you to get an IV started on your patient. So again, this comes into play with using both the gut feeling and the rational brain. Now, these cognitive processes are really adaptive. They change, they adapt, they move around, and they get better as we use them. And they are really important for clinical decision making and clinical judgment, although we got to remember they are not without liabilities. As I said a while ago, Dr. Daniel Kahneman demonstrates that these cognitive shortcuts can often lead to systematic errors, especially in the inexperienced medical provider. Now, in healthcare, these errors may manifest as maybe something like anchoring bias or confirmation bias, where one tends to favor the information that already confirms what I believe. Now, when we're looking at this, again, two of the things that we want to identify are the reasoning process, which basically involves thought, data, research, and other metrics to come to a conclusion. It's much like the old TV show, and I'm going to date myself here, of Joe Friday from Dragnet, where he would say, I want the facts, man, just the facts. And he was really, really good at that. Taking the time to analyze this information is an important tool when making good decisions. Now, here's the thing that you got to remember. The first part of that statement is key, taking the time to analyze the information. In some situations, we're not going to have a lot of time to make a decision. So we've got to do something. Again, we've got to try to get our students into that situation as quickly as we possibly can in the lab, in the simulation suite, so that they can begin making those decisions from a rational perspective. On the other hand, and that's the head, on the other hand, we talk about the heart, and this is the intuition part. You might find logical thinkers that are unable to understand your convictions based on your gut screaming out to do what feels right now. You're looking at this patient and they've got good vital signs, they've got good level of consciousness, but something inside you says there's something not right here. And so one of the things that I would tell you is to continue to look and to dig deeper, because there is a reason why you are feeling that way. I'm a big television watcher, and so I used to like the TV show Columbo, and Columbo was always like this. He always had a hunch. He always had a feeling that was deeper than the thought or the intellect, and it comes from the heart. Now, remember, when we're talking about the heart, we're not talking about the anatomical heart. We're actually talking about the brain. But the heart, as far as literature and thinking about it, is the cradle of our intuition. That's where our creativity comes from. And we look at the information that we're getting from our heart, from our gut, and we move on from there to see whether it is right or wrong. Head and heart are both going to be very, very important. Now, we talked a little bit about confirmation bias. Now, confirmation bias is a bias that involves favoring the information that you've already got that proves that you are right. We got a huge problem in our country today. Regardless of which side of the political spectrum that you're on, people don't want to examine evidence. They don't want to look at, maybe I'm wrong. And this is true whether you value yourself as a political conservative or you value yourself as a political liberal. In healthcare, that could be deadly for a patient. Confirmation bias is a pervasive psychological tendency that affects how we gather, interpret, and remember information. And this can lead us to making really bad decisions. And when we make bad decisions, oftentimes someone doesn't go home. Either it's us as the responder or the patient. When somebody has confirmation bias, they typically pay more attention to details that uphold and back up what I already believe, while poo-pooing or throwing off on anything that might be out there that would challenge their belief. Now, this can happen in any realm that you want to look at. It's not just politics, it's medicine. It is in with religion. It's in with relationships. So all of these things can come into play and be major, major issues. Now, in practice, especially in medical practice, confirmation bias can show itself in numerous different ways. So, for example, a researcher might selectively review literature or data that supports their hypothesis while they completely ignore or dismiss findings that challenge it. We've seen some situations, particularly within the pharmacology industry, of where this has been done so that we can bring a new drug to market very, very quickly because of the financial interests that are in there. The problem here is that when we have the selective memory or the selective evaluation of the facts, this limits the scope of information that we can encounter, which can, number one, deepen our existing beliefs and keep us from making new decisions. Now, the implications of confirmation bias across medicine are profound and dangerous. A paramedic that's prone to confirmation bias might diagnose a patient based on initial assumptions rather than thorough analysis. maybe even leading to a dangerous diagnosis. For example, we go out, we smell somebody that smells strongly of alcohol. Immediately, our first thought is, well, this is a drunk guy. There's nothing wrong with him. Why are you bothering me? But one of the things I'd like to stress to my students is that drunk people get hurt, drunk people get sick. And as a matter of fact, they're actually more prone to do so than people who are not intoxicated. The key here is acknowledging and mitigating any type of confirmation bias that we can. We're not going to eliminate it totally because that's part of the process of being a human. So one of the best ways of minimizing this bias is to deliberately and purposely view information and data that challenges what we believe. A real world example of this should be wherever you get your news from, watch the other network. If you're a Fox News devotee, you need to be watching CNN. Same way, if you get your news from CNN, you need to be getting some information from Fox. That helps to challenge your beliefs and make them a little bit better. Now, so the introduction of an updated registry exam makes us have to shift in how we are teaching paramedic and advanced EMT education. And I don't have any background or any hidden information on this, but I suspect that at some point in time, this will indeed trickle down to the EMT because the EMT is a healthcare provider. Now, this shift that we're talking about enhances a student's clinical judgment by effectively linking classroom learning with practical clinical experience. We've all heard the students say, well, I'm a hands-on learner. I'm a hands-on learner. Well, that's all well and good. And the example I like to give students when they come to me like that is the fact that when my daughter, she has her doctorate in social work now, she teaches at a university in Southern Michigan. When she was 4 years old, I taught her how to intubate. And she didn't know why she was intubating. She didn't know the indications or the contraindications of intubation. She just thought it was fun to hang out with dad. And I would bring her into class to let her demonstrate that intubation was a skill that was so easy, even a 4-year-old could do it. And this is the thing that we've got to do, is that we've got to begin pulling away some of those treasured beliefs that we've held on to for so very long and be examining them to see whether or not the science shows that they are the best for the patient. Well, how do we do this as far as this clinical judgment concept goes? Well, we go to active learning. Now, one of the things that drives me crazy is I'm very active in my church. And in my church, they have an incredibly awesome children's program. They actually built the inside of an airplane in one of the classrooms so that when the kids were in there for their weekly Bible classes on I go to church on Saturday, so they were in there on Saturday, but same thing for Sunday. They were immersing these kids in an entirely different environment. And then all of a sudden I kind of looked into the sanctuary and I see, as a teacher myself, I'm teaching from up in front and I like to ask lots of questions, but it's still mostly going to be lecture. Now, there's a well-established evidence base that supports the use of active learning. Now, the benefits of this are many, including improved critical thinking, which is what we want our students to be able to do, increased retention. That's going to be a great thing when they are taking the exams that you're administering, as well as when they're sitting for the registry exam, as well as increased motivation to continue to learn, as well as a drop in course failure, which relates back to our accreditation of the attrition process. It was interesting that Freeman and a group of his researchers found that without any active learning, with only the sage on the stage type of presentation where it was almost all given by lecture, students were between 1.5 and 2 times more likely to fail than students that had active learning that was going on. So what do we need to do? So let's go back to our ABCs. Well, first of all, we have to achieve active learning and application. We have to go back and we have to begin to embed active learning even within the classes in which we're doing lectures. And I'm going to give you some ideas for that in just a minute. Second thing we're going to do is we're going to build clinical judgment skills. Basically, throughout this whole process, we want our students to be able to make judgment calls, to make decisions. And we want to encourage them when they make the right decision, but then we also want to correct them and redirect them when they make the wrong decisions. One of the things I like to do in my class is to give my students what I call the Kobayashi Maru scenario, where no matter what they do, it doesn't work and the patient continues to spiral down. Students don't like that. They don't like it when their patient dies. All patients are supposed to live, but we know that that's not true in the real world. By doing that, now they're beginning to build up their clinical judgment skills. And then lastly, we connect the dots, okay? And we begin to say, why what we're learning in the classroom, how does that relate over into the lab? How does it relate into the clinical facility? And then ultimately, how does it relate within the field? One thing that drives me crazy is that when we go out and we have preceptors, and we've got some great preceptors in the central Kentucky area, so we don't hear this a lot. But occasionally a preceptor will say, well, you can forget about all of what you learned in the book. I'm going to show you how it's really done. No, you're not. That's actually a variation of what needs to be done from what you learned in the classroom and has been enhanced all through there. That's the part of connecting the dots. That's the part of putting it all together. So one of the critical elements of active learning involves the selecting of activities as well as questions that you're going to utilize in the classroom. In deciding which of these that you're going to do, consider the following. Well, number one, which one of the key lessons should the students take away from the session? And you need to limit this to one or two. Question number two is, what are the typical misunderstandings or challenges students face with this material? So, for example, how are you going to teach them to determine stable SVT from unstable SVT from critical SVT? Number three, what form of practice could effectively prepare your students for an assignment or an evaluation? What are you doing to get them ready for your exam? Now, based on the answers to these particular questions, this will help you to determine what you're going to do. And so throughout your lectures, throughout your labs, again, you can embed these types of activities so that the techniques that you are utilizing basically kind of follow this guideline. We're asking questions. We get the data from the students as far as what they know and what they don't know. We as the instructors will analyze that so that we can either affirm their answer or we can redirect it. And then we're going to make the instructional choices as the educators that want to, guess what, lead to more questions. And that's going to be the key part of this. So, why should you use classroom assessment techniques? Again, this comes from a Columbia Center of Teaching and Learning. And basically, it's number one, to assess prior knowledge and recall, as well as key thing here, understanding. Number two, to assess the student's application of knowledge and skills. There's that word application that we see particularly within the cognitive exam. And then lastly, to assess the student's self-awareness of the learning process. Students need to be taught how to take responsibility for their own learning. And this is one of the ways that we're able to do this. Now, here's some tips on implementation. Please don't go out and try to do this for every class, for every lecture at the exact same time. Start off really, really simple by choosing a technique. And I'm going to give you several here in just a minute. I'm going to share a QR code with you of where I actually got these so that you can go and look at the others. This is a multi-page document that has some really pretty cool ideas. Let's start off with one. Try it. See if you like it. See if it works in your class. Conduct at least one CAT prior to the first major assignment so the students begin to, number one, understand this is how we're going to learn. And number two, this is what is expected. Now, here's the thing. You don't have to do a CAT for every single lesson, for every single class that you're teaching, but it should be embedded within there on a regular purpose. Within these CATs, again, remember, we talked back at the beginning about why it was important for us to learn clinical judgment. As adult learners, that is the key. Your students, you may question this sometime, but they're adult learners as well, and this is still important to them. So help them to understand this is not busy work. This is critically important for them as far as their learning and their success. And then periodically report back to the students as to where they're at and where they need to be. So let's get to some of the ones that we're looking at. So some of these you're going to be familiar with, some maybe not. One is the minute paper. Basically, it comes, and I'm not a huge proponent of doing a lot of these at the end of class. I have a tendency to like to do them more so towards the beginning of class, because when you use the words in conclusion or are there any questions, that sets off the signal in almost all of us that, okay, learning is over, time to close up, shut the computer down, get ready to go get something to eat or drink or whatever. But this minute paper basically says, what was the most important concept that you learned in class today? What did you get out of this class that is going to be really important to you? These CATs should not be graded. There's no right answer, there's no wrong answer. And in some situations, you'll have students that will write a full page, others will only write a few paragraphs or a few sentences. Directed paraphrasing. One of the things that you can do is that once you've gone through and you've taught something that's important, like a VQ mismatch or the FIT principle, have the students now paraphrase this. I did a variation of this several years ago with an EMT class, of which I gave them different medical pathophysiologies, diabetes, heart attacks, strokes. And what I told them to do was that they had to come up with a 3-minute video that used no medical terminology and yet showed their an understanding of the concept. And I got to tell you, there were some really awesome ones. One of my favorite ones that I remember today is that the role of insulin. This team set up a scenario where they were going into a club, and the bouncer would let people in or not let people in. The bouncer was serving the role of insulin. Trust me, that group got an A on that one. This is a really, really good one that I love using because it gets students to learning more about high level questioning. And that's to ask them to write test questions that are then submitted to you. You can review them, give them feedback. And one of the things that I will do, and this kind of goes a little bit different from what I said a while ago about not grading this, is that towards the end of the semester, or well, our program is a 2-year program. Towards the end of that 2 years, our students will begin to be coming up with some really, really good questions. And I tell them, if I use your question on an exam, I won't tell you I'm going to use it, but you should be able to recognize it. So at least you should get that one right. Plus, I will give them a bonus point or two for that particular exam if it rises to the level of that particular question. Here's the thing you need to do, though. Don't only ask them to write the question and give you the answer, but also to give you a rationale as to why the right answer is right and why the wrong answers are wrong. This one I haven't tried yet. I just found this one, but I'm definitely going to try it because we're moving into capstone with my current class, is write a letter to future students. and get permission from your students to share this with your incoming cohort. And in this letter, what you do is you have them write, number one, why is study so important? Why are these concepts so important? And help them to write strategies that will help the incoming students to be successful. Don't allow your students to type these up on a computer. The most current research shows that when you write things out by hand, it solidifies it in the memory much, much better. So ask them to use their very best handwriting. I don't have very good handwriting, and so I have a challenge with that, to be able to share that either with their signatures or anonymously with the incoming class. And the last one I've got here, and if you want to go ahead and get your cell phones ready, I'm getting ready to pull up a QR code that will lead you to this document where you can download it. It's not my document, but you can download it and utilize multiple other activities. Is a bumper sticker. It's basically how do you summarize up in just a very short sentence what the concept is that you've been learning. Pull those in, and then you can share them again with the rest of the class. So again, here is the QR code for this particular document, and like I said, it was about 4 or 5 pages. I would encourage you to download it, look at it, go through it. I will share this again at the end of the presentation, so that if you don't get it just quite yet, you'll be able to take a look at it. So again, this whole measurement model is basically going back to that cycle that we talked about a little bit earlier. Look at cues in your students, recognize them of when they're struggling. We're all familiar with a dog that turns head to the side, and I've got a cartoon that shows students with their heads to their side, just to understand this is they're not getting it. And so when we recognize them, when we analyze them, now we have to go in and see to what depth that we're going to go through. Number 3 is we prioritize our hypothesis. What are we going to do as far as how are we going to answer their question? Learning styles are out, but learning preferences are there. And so sometimes students would have a preference for learning over one way or the other, but we learn by all of the different methods. And by developing your hypothesis, it's going to be keying in on what will be the best for the students at that particular situation. And then number 4, we come up with a solution. That could be utilization of the document that I shared with you, and then take action. Share this with the students, look at it, get that data back, and evaluate the income or the outcome from it. So what about your test questions? Okay, so one of the things I want to stress here is that if you are using, I'm going to make this is just Bill talking, okay? Not registry, not NNC, not EKU, but this is just Bill talking. If you're using publishers' test banks, if you're using any commercial testing or questioning database verbatim, without looking and editing and changing those questions, you're doing a grave disservice to your students. And as I said earlier, nobody's got time to go back and do a bunch of changes. And that's why when you build these exams, you've got to guard them with your life. Don't send them home with the students, because you're going to want to evaluate those. And that comes into play of doing an item analysis of whether it's just looking at, the students. 50% of the students missed it. Well, why did they miss it? Was it because we didn't cover it? Was it because it was a bad question? Or is it a good question because and the students just didn't understand it? Or if you go to a full statistical analysis, but don't use anybody's questions verbatim. Take them as beginning, take them as a starting point, and build them and change them so that they now begin to address what you want to. You can tell I'm pretty passionate about this, because again, back in my days when I was with the director of education here at the Board of EMS in Kentucky. I'd talk to educators and they would say, my class has a 95% average, and yet they can't pass the registry. My first question was always, where are you getting your test questions? Oh, I'm getting them from the publisher. They're the experts. No, they're not. You are. And I would always say, if there's your problem, there's a good starting point, and now you can move on from there. So the bottom line is we're kind of coming to the end here, and I want to give plenty of time for any types of questions or even experiences that you might have had, because we got a lot of smart people that are on this here. Is that for clinical judgment, this helps us to gain deeper insights into students' grasp of essential concepts. Some things are more important than others. They're all important, but we want to find out and we want to understand exactly where our students' learning is. The second thing we want to do is that as we work with our students, we need to be in a position of knowing the likelihood of our students being successful when we place them into some type of a critical scenario, whether that is in your sim lab or whether that is out in the hospital or out on their field internship or their capstone. The other thing that comes along with this is that when we're in that and we're beginning to get that estimate of knowledge of how they're going to succeed or not, that allows us to ramp up or ramp down the difficulty and the technicality of that particular process. And then the last part of this is to provide targeted remediation to reinforce learning. Students are not going to learn simply from your lecture. I got some bad news for you. Again, we got some folks on this call that I love to listen to, but you're not that good. I'm sorry. Learning takes place outside of a class, but we can help to remediate the students. I'm not that good either. Trust me. I know that I'm not. And so I stress to the students that if you want to do additional sessions based on your time frame, my time frame, so that we can build up this whole concept of clinical judgment, so that number one, ultimately, we want them to be good field providers, but they're never going to be good field providers unless they pass their licensing exam. Folks, those two are not mutually exclusive. We can have both of them by focusing in on enhancing the clinical judgment skills that they have. So it looks like that I've got about 6 minutes left. I'll kind of open it up for questions. And while we're taking any questions that may come up in here, let me bring up that QR code again to see if there is anything